With that very important context, I'd like to introduce our first speaker today, who is Jessica Petrick, a postdoctoral fellow at the National Cancer Institute, who is studying cholangiocarcinoma epidemiology and risk factors, and will give us an overview of these today.
Hello, my name is Jessica Petrick, and before I get started, I'd like to thank the conference organizers for inviting me here, everyone in the audience and on the live stream for listening, and I also want to thank Porter for that beautiful introduction. It really puts us into context. And I also want to thank the patients and caregivers that I had the privilege of meeting last night. Patricia, Terry, Jack, and Mary, you guys are really inspirational, and I hope that everyone here that's a patient and caregiver knows that you're really the reason why we're doing the research that we're doing. So thank you. So before I talk about the risk factors for cholangiocarcinoma, I want to start with a brief overview of the types of cholangiocarcinoma. So cholangiocarcinoma can be, there are two main types, intrahepatic and extrahepatic. Intrahepatic cholangiocarcinoma occurs in the bile ducts that are inside of the liver, and this accounts for about 53% of diagnoses in the United States. Extrahepatic cholangiocarcinoma occurs in the bile ducts outside of the liver, and this accounts for the other 47% of diagnoses in the United States. And this can be further broken down into distal extrahepatic, which occurs in the bile ducts furthest from the liver, and this accounts for 42% of total diagnoses, and then perihilar, which is also known as Klatskin's tumors, and this occurs right where the bile ducts join together, and this accounts for 5% of diagnoses. So when I'm talking about a risk factor, this is just something that increases the chances of developing disease. However, and I want to be very clear on this, we cannot tell why any one individual develops cholangiocarcinoma, and I know that's difficult for many of you in the audience to hear. But whenever we're looking at risk factors, we're taking and comparing a group of people that has a risk factor to a group that doesn't. And one way that I like to think about this is thinking about smoking and lung cancer. We know that smoking vastly increases your risk of lung cancer. However, I'm sure everybody in the room knows of someone that is either currently or formerly a cigarette smoker that's never developed lung cancer. And then we've all heard stories about individuals that never smoked and were never around smoking and went on to develop lung cancer. So it's nearly impossible to tell why any one individual goes on to develop cancer. The risk factors that I'll be going through today include characteristics, medical conditions, infections, and lifestyle factors. Starting with characteristics, men are more likely than women to develop cholangiocarcinoma. So for every 2 women that are diagnosed, approximately 3 men will be diagnosed with cholangiocarcinoma. Additionally, as people age, they're more likely to be diagnosed with cholangiocarcinoma. So individuals 45 to 54, there's less than 1 person for every 100,000 people that will be diagnosed with cholangiocarcinoma. However, individuals 85 and older, there's more than 5 people in every 100,000 that will be diagnosed with cholangiocarcinoma. Looking at this on a graph, you can see that going here horizontally, this is an individual's age in years. And so this goes from 45 to 85. And what I want you to pay attention to is that the numbers of people diagnosed for every 100,000 continues to rise as age increases. And I'm also showing you here intrahepatic in green and extrahepatic in blue. And this shows you again what I stated in the very beginning, the intrahepatic is a little bit more common in the United States. Next, looking by race and ethnicity, again, these are showing you the numbers of people diagnosed per 100,000, but that's not what I want you to pay attention to. I want you to pay attention to the difference in the size of the bars. So this is showing that whites and blacks have very similar rates of cholangiocarcinoma. American Indians and Alaskan Natives have slightly higher rates of intrahepatic on the left, but at roughly similar rates to whites and blacks of extrahepatic on the right. Hispanics have higher rates of both types of cholangiocarcinoma, and Asian and Pacific Islanders have the highest rates and are at the highest risk of cholangiocarcinoma. Next, to look at medical conditions, there are a number of bile duct conditions that are associated with an increased risk of cholangiocarcinoma. First, bile duct cysts. This is an inherited condition whereby these cysts cause dilation or widening of the bile duct. So at the bottom, you can see a normal-looking bile duct, and here you see this giant widening of the bile duct, and this can occur outside of the liver or in the bile ducts inside of the liver. And this is associated with about a 15 to 30 times increased risk of cholangiocarcinoma. One specific type of bile duct cyst is known as Caroli disease, and this is specific to where this widening only happens in the bile ducts inside of the liver. And this is associated with about a 40 to 100 times increased risk. So this is one of the strongest risk factors that we know of. But again, this is an inherited condition, and this is quite a rare condition as well. Primary sclerosing cholangitis and bile duct cirrhosis are both conditions that are associated with inflammation and chronic destruction of the bile ducts. And inflammation is something that you're going to hear repeated over the next few slides. So on the left, you can see a normal bile duct, and then on the right, you see an inflamed bile duct. And where these red arrows are pointing, that is where the bile ducts are narrowing due to this inflammation and destruction. Cholangitis is associated with about a 20 to 40 times increased risk, and cirrhosis about an 8 to 10 times increased risk. And then finally, gallstones and bile duct stones are both associated with an increased risk of cholangiocarcinoma. I'm sure everyone's heard of a gallstone. These form inside the gallbladder here, and the gallbladder is connected to the bile duct via the cystic duct here. So these stones can come out of the gallbladder and move into the bile duct, and they can also form on their own. These stones can form on their own in the bile duct. And these cause inflammation in that area. And these are associated with about a 4 to 14 times increased risk of cholangiocarcinoma. Other medical conditions that are associated with increased risk include inflammatory bowel disease. And inflammatory bowel disease includes Crohn's disease and ulcerative colitis. And you can see here on the left, this is a normal-looking gut. And what these diseases do is cause inflammation in the gut. So in the middle, you see Crohn's disease, and on the right, ulcerative colitis, and you can see the red and the swollenness and the inflammation that's occurring in the gut. And both of these conditions are associated with about a 2 times or double the risk of cholangiocarcinoma. Chronic pancreatitis is another disease that causes inflammation of the pancreas, and this is associated with 2 to 8 times the risk. And gout is a medical condition. This is actually a metabolic condition whereby the body cannot properly process uric acid. So uric acid crystals congregate in the joints. So you can see the crystals forming right here in the joint. And while this can occur at joints throughout the body, this is most common in the joint of the big toe. And this causes swelling and inflammation. And this is associated with about a 40% increased risk of cholangiocarcinoma, so less than double the risk. And finally, type 1 diabetes has been associated with about a 30 to 40% increased risk. Some infections that have been associated with cholangiocarcinoma. Hepatitis B virus is a viral infection that causes inflammation of the liver. This is passed via the blood, and commonly people that develop a chronic hepatitis B virus are actually infected very early in life, usually before the age of 5. So one of the most common routes of transmission for this is a mother-to-child transmission. And on this map from the World Health Organization, you can see that the countries in the darkest blue have the highest rates of hepatitis B. And this is primarily in Asian countries and also in Africa. Hepatitis C virus is another viral infection transmitted through the blood that causes inflammation of the liver. And again on the map, you can see some of the highest rates are in Asia and in Africa. And while this map, the US is in a very light color, indicating lower rates, I do want to point out that in certain sectors of the population, the rates of hepatitis are quite elevated. So specifically for the baby boomers, so those individuals born 1945 to 1965, they have higher rates than individuals born any other years in the United States of hepatitis C virus. And it is currently recommended that anyone born in those years be tested for this virus. And both of these viruses are associated with 2 to 3 times an increased risk of cholangiocarcinoma. Liver flukes are a parasitic infection that's been associated with an increased risk, and you can see this little liver fluke down here. These are parasites where their end host is the human liver. They like to live in the human liver and they cause inflammation there. These are primarily ingested in humans by eating raw and undercooked fish. And before anyone panics about this, these are not native to the United States. These are primarily found in Asian countries, and this is where the highest risk for a liver fluke infection occurs. And actually, the highest risk anywhere in the world occurs in northern Thailand, and I've highlighted that here. And this is also where we find the highest rates of cholangiocarcinoma. Liver flukes are easily treatable with medications, but in places like Thailand, there's really poor sanitary conditions, and people are often eating raw and undercooked fish. So even if people are treated, they often recur. And liver flukes are associated with about a 2 to 5 times increased risk of cholangiocarcinoma. And finally, I want to end talking about a few lifestyle factors that have been associated with an increased risk. Obesity, which is defined as having a body mass index of 30 or greater, is associated with a 30% increased risk of cholangiocarcinoma. And additionally, there's a couple medical conditions that are associated with obesity that also confer an even more substantial increase in risk, such as type 2 diabetes and non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease is a disease that's becoming more prevalent, and it's when fat accumulates in the liver. And this is actually associated with about a 3 times increased risk of cholangiocarcinoma. And while it's associated with obesity, this can occur in non-obese individuals as well. Physical activity has not been well studied in relationship to cholangiocarcinoma, but there is limited evidence to suggest that higher levels of physical activity are associated with a reduced risk of cholangiocarcinoma. Alcohol use has been associated with an increased risk, and in a recent study, we found that individuals consuming 5 or more alcoholic beverages per day had about a 70% increased risk of intrahepatic cholangiocarcinoma. And similar to obesity, some medical conditions that are strongly related to chronic heavy alcohol use, such as alcoholic fatty liver disease, confer a substantially increased risk of cholangiocarcinoma. Smoking is associated with about a 30% increased risk. And diet, similar to physical activity, has not been well studied in relationship to cholangiocarcinoma, but there is some preliminary evidence to suggest that higher intakes of fruits and vegetables may decrease your risk, and that tea may decrease your risk of cholangiocarcinoma. So with that, I want to leave you with some cancer prevention guidelines, because I feel like some of this presentation has been a little bit of gloom and doom about these risk factors. So the American Cancer Society and the American Institute for Cancer Research have developed these cancer prevention guidelines, and specifically the American Institute for Cancer Research has a guideline specific for cancer survivors. And in this, they state that after a cancer diagnosis, all patients should be receiving specialized nutritional advice that is from an appropriately trained professional to help support their medical treatment. And then once treatment is completed, they should be following the guidelines that I'll be presenting to help reduce risk of recurrence and second cancer. So the cancer prevention guidelines are to achieve and maintain a healthy weight, to be physically active, to eat a variety of vegetables, fruits, whole grains, and legumes, to limit the consumption of red and processed meats, to limit the number of alcoholic drinks, and to not smoke or chew tobacco. And with that, that concludes my presentation, and I thank you all for your attention today. Thank you.
Thank you, Jessica. That was a really interesting talk. We have time for some questions, so I actually had one to start with, if you don't mind. I was very curious to hear, you may have said this, whether the increased risk in inflammatory bowel disease, such as Crohn's and ulcerative colitis, is that independent of primary sclerosing cholangitis, the inflammatory condition that can associate with those conditions in the liver, or is it on their own?
I don't think that we actually know the answer to that. I will say in a recent study that we found this about 2 times increase in risk. There was less than 10% of the people that also had a cholangitis diagnosis. So it does seem like potentially it's independent, but I don't think we completely know, because there are a lot of people that are diagnosed with both.
Okay. And the reason I ask that is that Crohn's disease and ulcerative colitis are types of chronic inflammatory bowel disease that can cause diarrhea and inflammation and bleeding in the colon. And some of those people also have inflammation in their liver, a theme of Jessica's talk, called PSC, or primary sclerosing cholangitis, which is definitely a risk factor for cholangiocarcinoma. But we have seen clinically, I've seen a lot of people with ulcerative colitis without any known problems in the liver who have also had cholangiocarcinoma. So the question is whether one needs to have true liver inflammation or whether it's independent and can happen without the PSC. Are there any other questions from the audience? Maybe if there are several microphones up here in front, so unless your voice is much better than mine. Oh, yes. Great. So if you can step up to one of the microphones, that would be best, because then people listening in by live stream can also hear your question.
Have there been any studies done in terms of the environmental factors that increase the risk for cholangiocarcinoma? I had read one article that talked a little bit about the people that are working in the plastics industry or people in the automotive industry.
Mm-hmm. Yeah, there have been a few studies, and they've been primarily what you were saying, occupationally based studies. So they're very small, and they're very difficult to then take and transfer those results to the general population and what that means in terms of general population risk. But there have been a few studies looking at various environmental factors, exactly what you said.
Thanks. I have a kind of related public health question. Mm-hmm. We often hear about the liver flukes, and then immediately sort of the question goes to, well, that's in Southeast Asia, so wouldn't be connected to any of the fish that a typical American would eat. My question is, in terms of like a globalized food chain, have there been any research studies that have looked at the past or what might emerge in the future as a public health concern in where our fish is sourced from? If some of our fish is sourced from Southeast Asia, and or if it would be, what would be some of the public health mechanisms in place to guard against those risks? Thanks.
Yeah, no, that's a fantastic question. To answer that, no, I don't think that there have been any studies done, or at least none that I know of, that have looked at that and have tried to make that connection. So I think that that's a great question.
I could add maybe one.
Sure.
I think there are particular riverbeds and areas of water that are infested with flukes. I think they're usually freshwater or brackish water. Yes. And so the fish that are more often imported, I think, are not the kind that carry flukes, is my understanding, but I think it's not a widely studied area, certainly.
You mentioned non-alcoholic fatty liver disease as being 2 times. What are the signals to look for a person having that non-alcoholic fatty liver disease?
You can probably answer this better than I can.
That's a huge question right now, because in the clinic, whether it's primary care medicine or oncology or hepatology, GI doctors, fatty liver is a huge growing problem in the Western world owing to the increase in risk factors, including obesity, being overweight, and the exposure to the diet we have, as well as I mentioned diabetes already. There's not a great test for this. Sometimes we will pick up a fatty liver based on a routine blood work with liver tests done for other reasons. But there are many reasons that liver tests can be mildly elevated or fluctuating, including other medications or illness. And so it takes a liver biopsy to know that there's actual fat in the liver and inflammation caused by the fat deposition, which causes oxidative stress and inflammation, and eventually fibrosis and cirrhosis. Once somebody has fibrosis and cirrhosis, you can't really see the fat anymore. So after the fact, we can't always look back and say, oh, that was caused by fatty liver, because once it's fibrotic and scarred, it's too late to always make a definitive diagnosis. But it's increasingly in the awareness of the public health and primary care world, and so people are now building clinics for fatty liver disease monitoring and screening people based on both blood work or their risk factor profile. For example, if someone has borderline diabetes, looking for it, and then there are a lot of guidelines that need to be developed at determining how often to look for cancer. Because right now, both standard liver cancer, hepatocellular carcinoma, as well as cholangiocarcinoma are increased with fatty liver, and we don't really know what the best way to screen for those is.
Thank you.
Yeah, and I just wanted to add to that it's suspected that about 20% of the general population has a fatty liver. And like I said, it's not only in obese people. So it does create a problem, like you said, that you can only diagnose this truly via biopsy.
Hi. I was just curious, when you listed the risk factors, that have there been any studies done with Lynch syndrome connection to cholangiocarcinoma?
With Lynch syndrome?
Yeah, if you're familiar.
Not that I know of.
Okay.
Not that I know of. Do you know of any?
The Lynch syndrome can increase the risk of a lot of different GI epithelial cancers, from colon cancer to definitely small bowel cancer. We think cholangiocarcinoma. I definitely do not know off the top of my head what the relative risk is in Lynch, but I do have patients who've had cholangiocarcinoma or gallbladder cancer. Often, though, people can have the Lynch mutation. Not often, it's still rare, about 2.5%. Actually, I'm going to bring this up in my talk later. About 2.5% of cholangiocarcinoma patients have Lynch-type mutations, either in their whole body or in their tumors. That's different than asking what percentage of Lynch patients get cholangiocarcinoma. I think that's much lower. But it is, I think, an emerging question, particularly with the realm of immunotherapy, that has a predilection or improved response rates in that mutation profile of Lynch.
Excuse me, thank you, because my family has a history of Lynch syndrome, and I have Lynch, and then I got cholangiocarcinoma, so that's why I'm asking that it was connected, maybe.
Yeah.
Thank you.
Thank you.
I understand that for 9/11 first responders in New York, cholangiocarcinoma is one of the listed possible results. I was nothing like a first responder. I teach at a law school in Lower Manhattan. And when I was diagnosed with ICC 2 years ago, one of my faculty colleagues was also diagnosed with it at roughly the same time. It's not that big an organization. And I just wondered if there's anything to be said about the chance that you could get cholangiocarcinoma from being in the neighborhood a lot after 9/11.
I don't know that those studies have been done. I haven't seen any of the actual studies being done to say definitively. But like we started, there have been studies showing that environmental exposures to different contaminants, such as what would have been seen there, may increase the risk. So I definitely think it's a possibility. Thank you.
I wonder if there are any studies linking pregnancy hormones or HCG as a dietary supplement to lose weight and cholangiocarcinoma. I met a few people here who had found out post-pregnancy that they had cholangiocarcinoma, and just wondered if there's any research to support that.
To date, there have not been. One thing that we have tried to look at, and unfortunately, we don't really have a good population to try to do this in, because cholangiocarcinoma is so much rarer in women, is that we've tried to look at a variety of different reproductive factors. And then also, we currently have an ongoing effort where we're trying to look at different hormone levels to see if it could somehow be related, because we think that this could potentially be playing a role because it's more common in males than in females typically. So I definitely think that that's a great question, and we don't really have the resources to study it yet.
Thank you.
Thanks. I noticed that your demographic data did not go below the age of 45. Now, I realize we are probably a self-selecting social media and not statistically significant group, but but have you noticed any trends with younger, especially women? I am shocked to see how many women. I was 31 when I was diagnosed, and I just don't know if has any data been collected on that? Are there any trends you're noticing personally, or?
Yeah, so I actually have a talk on the trends tomorrow morning.
Okay.
And one of the things that is shocking in that, I do show the trends for individuals age 18 to 44. Okay. And it is increasing for both types of cholangiocarcinoma in the U.S. again, like you said, the numbers do get very small. So, and within that age range, it's difficult to tease apart because the numbers become so unstable to really make any distinction. But I will be showing that. And additionally, the rates are going up in both males and females.
Okay, thank
Yep.
you.
Hi, Porter.
And this may be discussed later as well. My question is, we know what some of the common of going over risk factors are. From my understanding, I didn't have any of those risk factors. Do we know the percentage or studies of those of us with cholangio that don't have any of those risk factors, or the percentage of that don't contain any of those risk factors? And secondly, to that percentage, does my risk factor, would that go up for my kiddos? Would it be hereditary? Would that be considered a higher risk factor for my kiddos to get it?
To answer those questions, your first question about the percentage of people that don't have known risk factors, I would say that it's thought that most cases of cholangiocarcinoma develop in individuals that don't have any, at least established risk factors. So that's probably more common. I don't know the exact percentage, but I would say that that's not uncommon. As far as your child, I don't think we can say anything definitive about that. There has been a recent study that we published looking at family history of various cancers and whether that increases your risk. Having a family history of cancer, if that increases your risk of biliary tract cancer. And we didn't see that, but again, that was based on self-reported data, so it may not have been very accurate, and I don't think I can answer that question definitively for you.
Okay, thanks.
Hi.
Two more questions, or last couple questions.
Okay, my husband had symptoms that I haven't seen anywhere, that he had pain in his left side, and it seemed to be like trapped gas, but he was told he had IBS with constipation for 5 years. And the doctor wouldn't look further. Finally, we got him to do a CT scan, and we found that 60% of his liver was covered in cancer. And I just kind of wonder, we also had a CT, he did have a CT in 2012 that showed several hepatic cysts. Is that related? I mean, could have been.
The inflammatory bowel disease?
Well, he had ICC. He died last July, but his pain was here, and when they did the Y90, this pain went away. So I'm just wondering if that helped clear this. I mean, could it be a referred symptom, or because I haven't seen pain in the left side in anything I've read.
Yeah, sure. Yeah, I
I think it's really hard to know
Yeah.
without seeing the scans, but certainly pain can be referred because stretching of the liver capsule can happen to the left side, and the brain doesn't always interpret the signals very well. But I'm very sorry to hear about your husband.
Hi.
Hi.
I believe the statistic that you showed, I thought was staggering, 40 to 100 times the risk if you have bile duct inflammation, bile duct cysts.
for Caroli disease, yes.
Okay.
That's a specific type of the cysts that occur inside the liver, in the bile ducts inside the liver.
Okay, and then before that, you also mentioned the inflammation in the bile ducts, right? And then the stones and how that also increases by quite a bit, your risk?
Yeah, by
correct?
about 4 to 14% or times.
So, okay, so my question is, can having a gallbladder that's been removed in years prior then be a risk factor? Has
Yes.
anyone looked at that? Yes.
Yes.
And why is that?
That is because, so you may think that if you had that removed and maybe you're not developing gallstones or having any issues or inflammation with that it might decrease your risk. But it's actually shown that for cholangiocarcinoma, the risk tends to persist at elevated levels. And it's thought that could partially be due that once you remove the gallbladder, there's no place to store the bile acid. And so the bile acid is then constantly circulating. And it's thought that's a known carcinogen, so that you're having higher circulating levels of that, and that can then increase your risk.
And does it then increase the risk because that then causes cysts or inflammation in the bile ducts?
I think it would cause some inflammation, but it wouldn't, the cysts are an inherited condition.
Okay.
So those are passed down in your family. They're inherited. They're not something that would just develop.
Okay, so for those of us, or people in the population that have had a gallbladder removed, that's something that doctors need to look out for then, correct? To make sure that everything is circulating, or is there anything, any kind of preventive?
Is there anything that you look out for specifically?
I think it's a huge population has had their gallbladder removed, and it's a very small, while it might,
Yeah.
I think it's very hard to parse out what the original cause of the gallbladder inflammation is and how that fleshes out to their future risks. So I think that's a very complicated answer, or no answer to a very complicated question just yet. But maybe
Yeah.
one final quick question, since you've been waiting, then we'll finish this session.
I've read various studies along the years about taking baby aspirin and how they tested a huge group of nurses over the years, and far less had cancer. And then I'll read another study years later that it really reduces the risk of this kind of cancer. And so I'm kind of assuming that you can have inflammation without knowing it. Should we be taking daily aspirin every day just for the in case? And is there anything that we can do? Because I personally believe that stress would cause inflammation in major cases, like being a widow or being laid off or something. So I was wondering if there was anything that could reduce the inflammation that might be caused from that stress.
Yeah, I think that that's a fantastic question. We looked at aspirin use in one of our studies, and we found more so among men than among women, it did appear that potentially a daily aspirin did have some impact on your risk of cholangiocarcinoma, a small reduction in risk. I think that that needs to be examined more fully. In this, we only had about 200 individuals with intrahepatic cholangiocarcinoma in that study, and while that may sound like a lot, it's really not to really determine fully what these associations are. So I would say that this is a conversation to have with your doctor and to see, based on your personal medical history, if this would be a good option for you or not.
Anything about the stress connection?
I don't think that that's been studied. There's been no studies of that I know of, but I think that's a great suggestion. Thank you.
Thank you, Jessica. It was wonderful.